I'm very happy to introduce a wonderful colleague. Julie Gray earned her doctorate in social work at the University of Southern California, and before embarking on her teaching career, she provided care management services to people living with dementia and their family members in the Seattle area. Since 2016, Dr. Gray has served as a member of the Washington State Dementia Action Collaborative. She's past president of the National Academy of Certified Care Managers and past president of the Aging Life Care Association. She has tremendous and comprehensive expertise and is going to be sharing today some expertise that she has on options, choices, and what you can do to help your patients make informed housing decisions. Welcome, Dr. Gray.
Thank you. It's such a pleasure to be here. So, yes, today we're going to talk about options, choices, and what you can do to help your patients or your clients, however you're referred to the people you work with, make informed housing decisions. So, I'm going to show you the lay of the land. If if my uh, let's see, let's go this way. So our learning objectives today are to talk about the various different levels of care and the cost of options for people who are living with dementia. We're also going to talk about how the 4Ms can be incorporated into our work with people when they need to consider different housing options. And then we are going to discuss the barriers, common barriers that come up when people are considering options and trying to figure out what they should do. So this is our roadmap. First, we're going to talk about the 4Ms, then the levels of care, the cost of care, which is kind of hard to wrap your head around sometimes, how to make decisions, and then how you can support a move. I also have a little slide in there, a couple of slides for you to start thinking about how we could shape the future and maybe make things a little bit easier as we have a growing aging population, and we start to think about even our own needs at some point in the future. So to start with a framework for this discussion, I just like to remind us that no matter who you are, staying connected to our home, our family, and our community is important to everyone, regardless of your diagnosis, whether or not you're living with dementia or anything else. Most people want to stay in some way connected to what they consider their home. And we know this is true because when there are surveys done, the majority of older adults say they want to age in place. So about 77% say they prefer to age in place. And we've seen over the last 20 years or so, and maybe even longer, because I remember back in the early 90s when I started working with clients, they started moving out of nursing homes, and we're seeing that trend continue. So over the past 20 years, we've seen a reduction in the number of people who are living in nursing homes, and more people are living in traditional housing, and also making use of different types of community-based residential care facilities. So when I say a residential care facility, usually I'm talking about, and the definitions researchers use are slightly different, but what I'm talking about in that discussion is assisted living. And in Washington State, we've been using what we call adult family homes, but some states refer to this as a group home. There might be different names depending on the state that you're living in. And in your state, there may be no such thing. I know many of my colleagues who are working on the East Coast, they only have options of assisted living or staying at home or a nursing home. They don't always have the same options that we have here in Washington State. We're also starting to see the use of assistive technology for helping people age in place. And I am going to refer you back to the wonderful presentation by Dr. Clara Barrage, who talks a lot about the use of technology in homes and working with people who are aging and need some extra help. So the research says that about 5% of individuals who are older live, and this is not just people who are living with dementia, although having dementia, living with dementia would increase the chance of you moving out of your home. So about 5% living in community-based residential facilities, 2% living in nursing homes, and 90% of older adults living in traditional housing. Now, one little caveat is the research I was seeing is not very current. They were looking at studies or surveys that were done all the way back to 2015, 2016. So this is lagging information. And I think as time goes on, we'll continue to see a move out of nursing homes. And that's, again, because of the state and federal policies that are shifting and really helping us think about how can we keep people at home or in other types of settings besides nursing homes. So let's think about this in a framework of the 4 M's of age-friendly health systems. And Barb talked about what those were just a minute ago. But I'm going to go and look at it from the standpoint of what matters to people who are living with dementia. And this really is a list of things that key points that people that I've worked with over the years have told me. They want to be treated with dignity and respect, just like all of us. And the challenge is when you have a diagnosis of dementia, there is a tremendous stigma that occurs. And so people are really worried about, that stigma and the loss of personhood. They want to find meaning and purpose and engage in meaningful activities. They desire inclusion and connection. And they're very concerned about their finances, worried about running out of money. Many of my clients over the years have also been afraid or reluctant to spend money because they want to save the money as a financial legacy for their family members. So that can be a barrier when we're trying to provide a little extra support. Some people, not wanting to spend their money. There's also a tremendous fear of becoming a burden and really fearing that idea of dependency. In our Western culture, we're very focused on being independent. And so any time that we aren't independent, we sometimes feel less than. Other cultures focus on interdependence. And so there's not as much of a fear, although I will say that when I work with people from all different cultures, they do prefer to have a sense of autonomy and independence as well, although they may be more willing to consider interdependence as a value that is close to their heart. Family worry about family caregivers and the burden that may occur as time goes on is a big issue that people who are living with dementia talk about to me. So they're concerned about their ability to be involved in decision making, and they want to be involved as much as possible and make meaningful choices. So when we think about mentation and dementia, I mean that those things go hand in hand. The first thing we think about when we're talking about dementia is an issue with mentation, but the challenge is that many people are not getting a diagnosis of Alzheimer's or any other type of dementia. They might be noticing a lot of changes. They may be going to their primary care provider and talking about the changes, but perhaps they're being told it's just normal aging, and there isn't always screening done. So one thing you can do is to use some of the brief screening tools. The Dementia Action Collaborative has created this list of brief screening tools that are free and fairly easy to use. So it's a tool that you could use. Of course, it's just screening. It's not a diagnosis. But it can help to point to whether or not there is an issue that needs further evaluation. Once somebody has their diagnosis, it's sort of a gateway to support, or it can be. It's not always, but it can be a gateway to gaining more support and more information and making some decisions ahead of time. Now, when somebody is living with dementia, we know that sometimes there are difficulties, which we call, behavior problems. I like to think about promoting positive behavioral health to reduce a premature move. And we can do that by focusing on non-pharmacological interventions, and then addressing these issues in a way that is meaningful. Sometimes you need to add a lot of extra people in the mix to problem solve, and a lot of teaching with the care providers and the family on how to approach somebody who's living with dementia. But if we can do so, we can reduce the amount of burden on family care partners, and also oftentimes reduce the chance of a premature move out of the home. So in an effort to provide education to family care partners and family members, the Dementia Action Collaborative has created this amazing dementia roadmap for family care partners, and it's a very easy to digest um, booklet. You can get it online. I've given you a link. You can also order copies if you have patients that you see in your clinic, or wherever it is that you're practicing. There are also handy tip sheets that can be provided to family care partners to help them address and manage some of the difficulties that sometimes arise when they are doing care partnering. And then for those of you who are working in primary care, I just like to point out to you a great resource of Project ECHO, which if you're, I believe, a primary care provider or an allied health provider, you can get help if you don't feel confident in making a diagnosis of dementia, or you're having some challenges managing different issues that are coming up. That's a great resource for you, where you can go and meet with an interdisciplinary team and problem solve issues and learn about issues that might help you to manage the challenges of the patients and the clients that you're seeing. So let's see if I could get my computer to change. It's always technology, right? We'll do it this way. Medication, minimizing polypharmacy. And then I really just like to hone in on the importance of considering the dosing schedule, if at all possible, minimizing it. I can tell you that that the more medications a person is taking, and the more often they have to take it, not only does it impact the adherence, but it also creates some burden sometimes on the care partner. I'm trying to not only remember, but maybe to get the person to take medication. But it can also increase significantly the cost of care if somebody moves into a residential care community. So this is important to keep in mind. And always we want to try to minimize polypharmacy, also because of the potential side effects that may be occurring. But from my social worker hat I'm putting on, I'm talking about the quality of life and the cost of care that can go significantly up. Um, I've had clients who wanted to stay at home, and I'm thinking about a woman I worked with young onset Alzheimer's disease. One of her goals was to take her medication for Alzheimer's. I think it was donepezil that she was taking. She wanted to take it regularly, and she was living alone. And so we did implement a medication management box that would remind her. It would have a little alarm to go off, and she would take the medication out, and then that process would turn off the alarm. And it worked well for a little while, but in time, this didn't work anymore. I came to visit her and the alarm was blaring and she had no awareness of it. So we had to do something different. And that different thing was to add a companion to remind her to take her medication. So these things can work for a little while and may delay the need to add extra help and support in the home, but they have to be managed and monitored closely. And then, of course, always working with a consulting pharmacist if you have access to it. And then just thinking about Project Echo as a resource too, where, as I said, there's an multidisciplinary team that you can tap into if you have questions. So issues of mobility, thinking about the disability model and treating patients who are living with dementia as if they have an acquired, because they do, an acquired cognitive disability, and involving therapy to enhance and maintain the person's function and their strengths. And I've added in this slide speech therapy. It's not really related to mobility, but it all ties together. Physical, occupational, and speech therapy are wonderful resources where we can help people maximize their current skills, give them tools to make adaptations into their environment, and to do a lot of teaching with the care partners to help them be successful in their role. And so I just can't stress enough the importance, the magic wand that my colleagues who are physical, occupational, and speech therapists have. I don't think we tap into their wisdom enough, and I would really encourage us to keep reaching out to them to make sure that we're using their wisdom and their knowledge to help our clients maintain and stay at home, because that's what matters to them as long as possible, and to avoid a premature move. And of course, in that process, we also have to look at how the home is set up and make sure that we can make modifications if necessary. I will say one of the challenges is that many people do not live in accessible homes, and modifying the home can be very expensive. I've seen figures from $10,000 to $100,000, which is quite significant and not feasible for a lot of people. All right, so now that I've talked about the 4Ms and sort of how we think about framing this idea of options for where people might live, I'd like to turn now to looking at the different levels of care. And if you are familiar with this, that's terrific. And knowing that the nursing homes are our highest level of care, then in Washington State anyway, we have group homes that provide, I would say, almost the same level of care as nursing homes, with maybe a few exceptions. They probably are not going to do tube feeding or really complex nursing tasks. Some of them may be able to do sliding scale insulin, but it just really depends on the particular home. And so, they provide a very high level of care. In Washington State, the adult family homes, and I believe in Oregon as well, there's a Medicaid waiver program where adult family homes are covered under a Medicaid benefit. So this is great because they're more affordable than living in a nursing home. Then we have underneath that a little slightly lower level of care would be memory care in assisted living. I do want to tell you though, and I can only speak to Washington State, we don't actually have regulations in Washington State as to what is considered memory care. Any assisted living could say that they have memory care, and that definition could vary quite significantly. Sometimes it just means that staff have been trained on how to work with people with cognitive challenges. And other times it might mean that they actually have a special secure unit in their building. So, so this idea of memory care could be quite variable. Generally, I've found that memory care typically has a higher staffing level. Although I will tell you that in this current era that we have staffing shortages. And so every single community, from nursing homes to assisted living and even home care agencies, are having trouble finding enough staff to provide the necessary care that, to meet the demand that's there. And then we have independent living communities where there's not really a lot of services available unless you hire them like you would if you were living at home. But they do sometimes provide some social activities. And then finally, we have these things called continuing care retirement communities or life care communities. And these are really kind of a special, unique type of community because they typically include all levels of care. They will have independent apartments, usually assisted living, and many of them have either on-site skilled nursing units, like a nursing home, or they may partner with another place or an entity that belongs into their group. They might have a nursing home that's used. And so I'm thinking about a community here in the Seattle area. They don't necessarily always have on-site skilled nursing facilities in their units, but they will have a contract with somebody else. So so the other thing I want to tell you about, and we're going to look at the cost of care, is that in assisted living and in memory care, you will have extra fees if you need help. And so the fees that I'm going to show you in a few minutes only consider the room and board. Every single community looks at and decides how to charge for that extra help in their own way. So there's not a standard way, and the fees will vary quite widely. And this is one reason why it's very difficult for consumers to try to figure out what's the best option and how much will it cost. So before we look at the cost, I did want to talk to you a little bit about how long people will need long-term care services. And typically it's around 3 years. Now, women might need it a little bit longer, men a little bit less. But this is an important thing to keep in mind when families are doing some planning and they're considering how much is it going to cost us to provide care and support if we add extra care at home or if we take the leap and make a move. So 20% of people are going to need care for 5 years or more. So that's sort of the wild card, and why it's so hard to do planning, because is it going to be 2 or 3 years, or is it going to be 5 or more? And it's really hard to predict. We don't always know. Um, what we do know is that maybe about a third of people who are about 65 years old may never need long-term care support. And my mother is an example of that. She died suddenly and unexpectedly in her 70s. And I actually, I had always been thinking about how is she going to get the care that she needs, and what were we going to do to try to help her if she ever needed care. And she just died suddenly and unexpectedly, and she didn't ever need to have that care that many other people do. And my father, on the other hand, who had a stroke, did need care at home, and that was a significant cost, and I can talk about that in a few minutes. So the average length of stay in assisted living is about 22 months. And this comes from the research and also my conversations with different communities, and ask them, what is your length of stay? And surprisingly, they say about 22 months. Now, this is important not only for the planning, but when people move to assisted living, sometimes there's a community fee that they have to pay. And that fee can vary. It could be, and it would be like a deposit, or, you think about a community fee. What does it mean? Well, it means different things. And it could be between just a couple of $1,000 to, 10 or even 20. I've seen $20,000 to move into a community. And if you have a lot of resources, that might be okay. But for the vast majority of people, that's a significant amount of money. And I like to have people think about the cost of that community fee, and thinking about it's usually non-refundable. You're going to be probably needing to stay here for about 2 years. And does that make sense for wherever you are financially? And then I think it's an important note that, and probably many of you do know, that most care is provided at home by unpaid caregivers or family care partners. And this is a significant savings to the person who needs help. And it also means that those care partners are not in the workforce, they're not saving for their retirement, and they're doing a lot of work to support their loved one, and making sure that they're safe at home and they have the support they need. I think unsung heroes are unpaid family care partners. Okay, so who pays for long-term care? Well, it may not surprise you. I'm not sure if it does or not, but Medicaid is the largest payer for long-term care services. And those who don't qualify for Medicaid, you have to be pretty low income, and I'll show you in a minute what the income limits are. Um, if you don't have the money to pay for long-term care services, you have to spend down your money, or you qualify for Medicaid after a certain amount of time. I want to stress this because many of us know the difference between Medicaid and Medicare, but I can tell you that so many families and people who are older that I talk to, they really don't know the difference. And they believe that Medicare is going to pay for their long-term care services and support. So they may not do a lot of financial planning ahead of time. And so it's kind of a shock to them to learn that Medicare doesn't cover the cost of in-home caregivers. unless they've had a hospital stay and they need some sort of rehab. And then it's not long, a full day of caregiver support. It'll be intermittent nursing, physical occupational speech therapy, maybe a social worker, maybe a bath aide for, an hour or two, but there's going to be a little bit of that time. And then some people, of course, if they are in the hospital, they might qualify for Medicare to pay for some skilled nursing time for rehab. And again, most people are not going to use up that 100 days that they have available. It'll be a very short amount of time after a 3-day qualifying hospital stay, and it doesn't cover for ongoing care if it's needed. So this is an area that families often need a lot of information about. And sometimes, as I said, it can be kind of a shock to them to find out that it is not covered. And I'm not going to get into the Medicare Advantage plans because those are all different. And you can access some services without that in a skilled nursing facility without that 3-day stay, but that's a whole that's a whole nother conversation. So just know that there are some differences depending on if it's regular Medicare or if it's an Advantage plan. So let's quickly look at Medicaid, and you can see here that you have to be, quite impoverished in order to qualify for Medicaid. But not only do we have to look at the person's financial status, but we also they need to meet the amount of care that's required to qualify. So they may be very low income, but they might not have enough care needs. So there is a standardized assessment that's completed in order to evaluate whether or not the person qualifies for Medicaid, for long-term care services. And there are a whole variety of programs. And ever since that we have the Accountable Care Act, there's even more services. And I'm not as up to speed as I used to be. These resource income limits mostly change. And so you have to go back and check if you're not working in this space on a regular basis. And I've given you some links on the slide that you can go to find out in your state what the programs are and what the resource limits are and the income limits are for programs in your particular state. And that's the American Council on Aging link. If you're in Washington State, you can go to washingtonlawhelp.org, and that provides a lot of information, questions and answers, and helps. It's really consumer-friendly information that families can download and look at that information and receive help to kind of learn how to navigate that system. Okay, here we're going to look at the medium cost of long-term care. Please note that this information is only current to 2021. And I've taken a look at the different costs based on the state. So I understand that we have a lot of people who might be participating in this webinar from states that are close to Washington, or Alaska, Idaho, Oregon, and Wyoming too. And if you're from any of those states, thank you for joining us. And I know this is a really busy slide, but I wanted to show you how different the cost of care will be depending on the state you're in. So in the green font is the low, and the red font is the high that people will pay. And you'll see that there's quite a variety of prices that people will pay. What I'd like you to notice is that the adult day center is probably the most cost-effective way to get extra support. And that usually is a 6 to 8 hours of respite care and engagement for the person who needs help. And it is one of the most affordable ways to get support, but it also is probably underutilized. And I would then also add that sometimes there's not enough capacity in every location. So it is something to explore in your area, and it's a great way to get affordable support for people who need some more help, or for families who need some respite. The other thing I want to point out to you is the home health aide. We think about having, caregivers come into the home. And as I mentioned earlier, there is a shortage of direct care workers. And that means that it is hard to find people to be available. And I'm hearing from people that they're not always getting consistently the same person to come into their home. And then I also want to note that when you are hiring help in the home, typically agencies are requiring a 4-hour minimum. So when we look at the hourly fee, that's one thing, but then we think about the cost of 4-hour minimums, and then we think about with our clients, how much could they actually afford to hire a caregiver in the home, and it could be quite expensive to do this. Now, before our talk today, I reached out to some colleagues of mine and I asked, in 2024 in the Seattle area, what are we looking at for hourly rates for aides to come into the home? And I was hearing that there's for sure a 4-hour minimum. And typically we're looking at, if you're going through an agency, about $45 an hour now. And you can see how in the Seattle area, that's almost a $10 increase from what it was in 2021. And that's, that hurts when you're trying to piece together care in the home. And I will also say that, sometimes people can afford to have a few hours of care, and piece that together maybe a few days a week. But if the person starts to need a lot more care, and we're looking at 24-hour care, the rate goes up significantly. And currently in the Seattle area, we are looking at, through an agency, paying about $650 to $800 a day for care in the home for 24-hour caregivers. And then if you hire a private person, you will be paying about $425 a day for 24-hour care, but that does not include the cost of taxes and all the other things that go along with that. So by the time you're paying taxes, you're probably close to that $600 amount that is being paid on the lower end in some of the agencies. Assisted living, as I mentioned before, now we're going up into the levels of care. Assisted living, we can see that the prices greatly vary depending on the state you're in. And I want to remind you that when you see this number, we are not talking about the extra care that somebody might need. So if they have multiple medication passes, that's going to significantly drive up the cost, and it will be added on to that base rate. If they need help with dressing, with bathing, escorts to meals, that will increase the cost. And each assisted living community will charge different rates. Some of them have flat rates for each individual thing that somebody needs. Others have tiers or levels of care that include certain amounts of things, and it just really varies. And so, from a consumer standpoint, this can be very difficult to compare the cost of an assisted living, that's 2 blocks away versus one that's a mile away. They're going to charge things differently, and so the family may need assistance trying to help sort out what the actual cost of that assisted living might be. And they can get very overwhelmed trying to sort it all out. Then we see that nursing homes are the most expensive type of care, and very expensive. And so you can see why there's an incentive from the state and federal government to try to get people out of nursing homes into alternative care settings, not only because it's a preference of people who often say, I don't want to live in a nursing home. That's the scariest thing ever. They have a lot of ideas about what that means, and also because of the cost of it. As I mentioned, in Washington State, we have adult family homes or group homes. This is a very cost-effective way to provide care in a very small, intimate setting, and it can be very home-like. There's pros and cons to living in an adult family home. Usually there's not the amount of activities that would go on in a nursing home or assisted living community, but it really depends on the particular adult family home. Now, interestingly, in 2021, we were seeing in the Seattle area, and I only have information for the Seattle area, the pricing was about $10,000 a month. And of course, they would require an assessment of what the care needs are, but there aren't little added extra costs unless there's incontinence care. There might be an extra cost for incontinence products, but this is pretty much an all-inclusive price. And interestingly, in 2024, I am hearing that the pricing for adult family homes in the Seattle King County area is still about $10,000 to $12,000 a month. And so it stayed pretty stable when you compare it to the cost of having aides coming in the home. So this cost of care really will rise, and it has a lot to do with supply and demand. Now, this median rate in 2021 and the change since 2020, it's kind of a little bit unfair to show this because we were like in the midst of a lockdown, and it was very hard in 2020 to get home care workers and workers in nursing homes. And so, there was a big change in the pricing structure. That said, it continues to be hard to find workers, and there's a growing demand. And so I do anticipate that it would be not surprising to me if we continue to see this kind of annual growth rate in the cost of care. And so this is something that we need to really take note of for our own selves, for our clients, and realize that this is going to be a challenge that we're all going to be facing as far as I can see into the future. So I also want to share with you this great study that was done that talked about the forgotten middle, those middle income individuals, older adults who fall into that middle income range, which is quite wide if we look at it, around $25,000 a year to $95,000 a year. But it is estimated that 54% of our middle income older adults will not have adequate financial resources to pay for long-term care. And that's why we created the Washington Cares Fund in Washington State, which is the first state to create a trust fund that's like a long-term care insurance. It's very modest, only $36,500. And when I just told you the cost of care, you think, how can that help anybody? But it really does help people avoid going on to Medicaid, and it can be just enough help to help them make some modifications at home or pay for respite care and help them to avoid spending down to Medicaid. And this is probably projected to save the state almost $4 billion in Medicaid costs by 2052. So what drives decisions about moving to supported living? Certainly financial resources. We see crises occur where somebody falls and then the care can't be provided at home, or the caregiver is getting burned out. The health status of the patient may change to a level that's unable to manage at home. And a lot of other things can go into the decision-making process. So now I'm going to talk about the challenges and the barriers that families have to accessing the various choices in long-term care. So there are access issues, psychosocial issues, issues related to fit, and financial issues that we see. So some of the challenges related to access issues are, as I mentioned, there's a lot of difficulty navigating the different systems, and there's a growing need and not enough help available. And then the low reimbursement from Medicaid can sometimes be a barrier to getting the help that that the person needs. So what can you do as a provider? And that would be to encourage pre-planning as much as possible. And if the person does have a diagnosis of dementia, then they can participate in planning early on in their early stage before a crisis. They can start to learn what's available and make their preferences known. And then I think as providers, we can help manage expectations about the speed of accessing services. We could encourage our clients to get their name on a waiting list if they have a preference of a place that doesn't quite have an opening. And then we can also refer them to the PACE program, which is an all-inclusive care for the elderly. And it's a multidisciplinary team where they can access a lot of different services and supports. Usually they're Medicaid eligible and meet the level of care for a nursing home. So they need quite a bit of help to access that program. I have a link at the end. Psychosocial issues. Patients have concerns about their autonomy and dignity and their willingness to accept help at home. The capacity of the individual might change. So how do we deal with these things? We do a lot of listening, building trust, exploring what options they would accept, and making sure that if you have a relationship with the patient or the client, referring back to statements that they said that they were worried about burdening their family members, or they were worried about the cost of care, and now the cost of care has escalated because they need so much help at home, and this is not a sustainable option financially. So reminding them, starting slow, starting with the least amount of help slowly, and then having the client start to accept more help. Telling them that maybe we try it for now and reassess, see how it goes. We can also help families accept risk. I've had clients that have taught me not to bubble wrap them. You know, everybody wants to, have them in a secure memory care unit, but that doesn't always work. And you can get a lot of resistance if you start to go too fast and try to bubble wrap the person and make sure that, they don't have any risk of falling and there's never a problem that happens with them. If we can talk to families to allow some risk to occur, then slowly building trust and then adding gradually extra help, that can be really helpful. I'm not going to talk about technology because I'm going to refer you to Dr. Clara Barrage's um, webinar for that. So issues related to fit. Families, as I mentioned, don't always know what the different levels of care are. And so they want to select the place that looks the nicest, but it may not meet the actual care needs of the individual. They also may be choosing unsustainably, financially unsustainable options. And so we want to help them understand that the cost of care can increase over time and sort of do some planning with them about how much money does the person actually have, and how long will it be to spend down to Medicaid, and whether or not the place they're living in will actually accept Medicaid when that time occurs. We also have issues with young onset patients who don't easily fit into long-term care settings. I had one client in her 50s who, the first time I met her, she was so physically fit. She did a headstand for me. I mean, she was just really physically fit. You can imagine, as about 6 months later, she needed to move into memory care, and yet she continued to be very physically active. And she had been a consultant, and she really wasn't going to fit in with the 80-year-olds who were living in the memory care area. So what we did was we worked with the staff at the assisted living and memory care community, and they gave her a meaningful job. She had been a consultant. They made her a consultant, and she had a job, and she had a hotel room like she had been used to, flying around the world, having a hotel room. And she had a job of observing what was going on in the community and reporting back. And they didn't just make it, oh, you're our consultant. They actually engaged her in discussion about what her observations were. And it worked really well. And then we added extra support for her getting out and being physically active, because the activities weren't a great fit for her, but we found other ways around it. So if you work with the staff in the various communities, they are often very creative. And if you need help, you can always reach out to a social worker to support the family and problem solve. Issues related to finances, we talked a bit about this. I think the main thing is to make sure that families understand the difference between Medicare and Medicaid, and to tap into the resources that are available that are a little bit lower cost, adding extra support if possible from possibly unpaid family care providers, or people who are willing to come in and support that primary care provider in home settings can be very helpful. And then screening for veteran services, which the person may qualify for other benefits that you don't know about if they are a veteran. And I'll talk about that in a minute. So as primary care providers, what can you do? You can provide that diagnosis, encourage the family to plan ahead, link the family with resources that are appropriate in your community. And if you don't know what they are, I encourage you to go out and check them out, or make relationships with social workers, home care nurses, and hospice nurses. They're in and out of these communities all of the time. They can provide you with their firsthand knowledge about what each community is like. Consulting with specialists if there are complex behaviors, and just remembering that making a choice about a care transition or a housing transition isn't as simple as it seems quite on the surface, and the family may need a bit of extra help. I think I've talked all about this, mostly just applying the 4 M's and making sure you're an ally for the patient and the family, encouraging pre-planning, and maybe helping the caregivers reframe what's going on and accept that they can't do it alone. So instead of saying, instead of asking, how can I get this done? Who can help you get this done? And helping them to do that little bit of reframe may allow them the opportunity to think about how they could get some extra help. Um, so, what can we do as a society? Well, I sure wish that our homes would be built to age in place and our communities would be easily walkable and accessible. Not always the case, but we can keep working towards it. I think promoting programs like the Washington Care Fund is going to be a very helpful policy. I'm hearing rumors that there may be an initiative to try to pull back this plan in the state of Washington. So I know a lot of people disagree with it, but I think it can be very helpful for families, especially when you think about those middle income folks who don't really have enough resources to pay for long-term care. This can be something to support them to make, choices to maybe stay at home longer and get a little bit of extra help. Improving Medicaid reimbursement could be very helpful, respite services, and strengthening family and medical leave policies. There are a lot of options for growing older in the community. Not all of these work well for people who are living with dementia. I would say that multi-generational and intergenerational housing is something that a lot of people started looking at during the pandemic. And so this is something that some families are considering. And there's a little video you can look at if you're interested in learning more. But there are lots of ways that we can be creative, and I would encourage you to sort of start thinking outside the box and promoting these options in your community. Here's a list of resources that I talked about today. There's a whole boatload of them. So I wanted to make it easy for you to go ahead and just have one page where you could go on some of these links. And maybe explore a little bit further if you have questions or you need to refer your clients to a place to get some extra help. And then before we wrap up, I want to make sure that you know about the Veterans Aid and Attendance, which is an enhanced pension. I am not an expert in this particular benefit, but it is sometimes overlooked when we are working with veterans, and it can pay for the cost of home care, assisted living, and adult day programs. This is for wartime veterans or surviving spouses who were in active duty at least one day during World War II, the Korean War, Vietnam War, or the Persian Gulf War. And this is an extra amount of money that they can receive for their care and support. There are some income and resource limits. But you can see on this slide, this is tax-free money that could go a long way to helping them get the supports and services they need. It usually takes 6 to 9 months to get an eligibility determination, but that application is dated when it's received, and that if they are deemed eligible, the amount of money would be backdated to the date the application was received and they were determined to be eligible. So that's something to keep in mind. I always just recommend working through one of the VSOs who will help navigate the system. It's a very complex system, and so you really need to know what you're doing to help the veteran be sure to access the benefit if they're eligible. So with that, I am happy to answer any questions you might have. I know I speeded through a lot of this, and I'm happy to answer any kind of questions that are burning for you.
This was just great, Julie. I have to say there was I think it was quite eye-opening for a lot of the attendees. Way back at the beginning, you had sort of talked about the disability model and things to be assessed, and Sheila was actually wondering about whether speech therapists work on more than swallowing problems.
Yes, absolutely. They do. They do a cognitive assessment and they have so many great strategies if somebody's having difficulty communicating. And so they're just a huge resource that I think is underutilized. And there is a wonderful webinar that was done this spring by Dr. Gallet, I think is her name,
Yep.
and it's incredible. So I hope that you go ahead and look at that video. It's she really goes through all of the ways that a speech therapist can help.
I'll post the link for that in just a second, catching up on a few things here. Um, let's see. There is a thing in the chat about your discussing the VA, and Neva is saying there are numerous programs in the VA that provide caregivers such as homemaker, home health aide, veteran directed care, caregiving
Yes.
stipend, etc. So always ask if the patient or a person is a veteran, and I think you'd agree with that based on our conversations that we've had.
Absolutely. I just happened to only note this one program, but I think there are a lot of programs through the VA that I don't even know how to access. And I go to my colleague, Chris Frederickson, who's at the VA, if I have a question, because she knows much more than I do. But I think reaching out to the VSO or encouraging the client or patient to do so. Some people have negative connotation with the Veterans Administration, so that can be a barrier. But if they know they might be able to access extra supports and services, maybe that would be something to overcome that barrier. Each person is going to be different.
Great. Well, I had a couple of questions about the PACE program, so I thought I'd check in with you on that.
Yeah.
Someone was wondering if you have any cost estimates for PACEs, and your link I'm going to repost in the chat here.
Yes, I put a link. Not every state, I think it's 33 states have a PACE program, and I want to say Pennsylvania calls it something different. I don't know what it is they call it. But the if somebody is Medicaid eligible, there is no cost for it. And if somebody is not Medicaid eligible, there is a cost. I don't know what the cost is. Usually, somebody might be spending down to Medicaid, and could be one way that they're, you know, doing that. But there's a great interdisciplinary team, and the folks in that particular PACE program become the primary care provider. They have access to long-term care services, including adult day programs and help at home, and even in the Seattle area, maybe contracts with different adult family homes. And so it's a wonderful, and again, possibly underutilized program. They're not everywhere. So you would have to go onto that link also that I gave you. This link I put in the chat is slightly different, but the one that's on the slide, I think you can search for a PACE program if you have one in your area.
So Amy is saying without Medicaid, PACE in Portland metro area costs about $8,000 a month.
Yeah, it's I think again, if somebody was spending down to Medicaid, it might make a lot of sense. 8,000 a month, but they're getting all of that extra support too. So to keep in mind, that might be less expensive than hiring care in the home or moving to an assisted living community. So there's a sort of a cost benefit analysis, and the PACE there's a social worker in the PACE program, and maybe just calling and asking and problem solving and trying to figure out for your particular client if it makes sense, is a good idea.
And Mary Zeitner is wondering, are there any PACE programs north of Seattle that you know of?
I don't know of any north of Seattle. I know of one in the Seattle area. You would have to go onto the website and do a little search.
Okay, back to, oh, here she said, what is the name of the precursor of PACE that started in the Chinese community? Do you know about that?
Oh, you got me stumped there. I do not know. I
Interesting.
don't know.
Maybe if someone else does, they can post it into the chat. Oh, it's in San Francisco, she says. Well, I'm going to go
Okay.
back to the VA while people think about that for a minute.
Yes.
Linda said the VA has a new program in Wyoming called Veteran Directed Care. Additionally, her husband is not service connected, but now that he's qualified as hospice, the VA will care for him in their facility at no cost to her for the duration of his lifetime.
Wow.
That's
Yeah.
incredibly amazing, Linda.
It
And
is.
my
And
regards to
and
you and
that's
your
why I think
husband.
VA programs are very underutilized often. And so it really pays to call up and see, see what's possible.
And Samson Wong said the PACE program that started in San Francisco is on lock. I remember hearing that.
Okay.
Yeah.
Yeah.
Thank you so much. Well, Maggie is wondering regarding group homes accepting a client on Medicaid. Could you talk more about the Medicaid waiver program? Her experience is that most group homes require a couple of years of private pay before conversion to Medicaid.
Yeah, there's a mix, and that's true for assisted living as well. And that's why it's really important to know how long somebody needs long-term care, because you can see many of them will say 3 years, and that sort of exceeds the amount of time that normally you would need care. And so basically, it's private pay. It really depends on the area you're living and working in, because in the Seattle King County area, I can really feel for the providers, um, that they are not getting reimbursed enough to cover their costs. So it's very hard in Seattle King County to provide services for people on Medicaid. There are a few places that will, and DSHS, the social worker, often can help locate. You don't have you don't have very many choices at all, and so you just kind of take what you can get. And this is another reason why a PACE program might be worth it if you're on Medicaid, because then it sort of opens up other options and that are available. But again, Medicaid, that's not available everywhere. Same with assisted living. Some might say they'll accept Medicaid after a certain amount of time. I just give a word of caution about that, because not only are they possibly going to say 3 years, but I have seen some communities that in the time the person is spending down to Medicaid, they're paying privately, that community is sold, and then the rules change. And so it's a little risky, but sometimes you don't have very many choices, but that is a big challenge for folks who are paying for care using Medicaid.
I noticed that Mary Pat put something in the chat, and I was just about to ask if there was anyone from the AAA's on. So, Mary Pat, I've uh, whatever I'm supposed to do to allow you to talk so you're not muted anymore. If you have anything more you want to add to this discussion,
For the pay sites?
yeah, and the
Oh,
Medicaid waiver issues.
yes, well, first of all, thank you, Barb. There's a lot of pay sites. If you just Google it, you'll see there's North, and there's some in the Spokane area. So that's one thing. And I really agree with you, Julie. Thank you for an excellent presentation that it's really weighing the pros and cons of the cost. I was taking care of my former husband and we had to pay privately and it was over 20,000 a month for in-home care.
Yes.
An adult family home in Montlake Terrace was charging 9,000.
Yeah.
And so some of the adult family homes, it would be important to find those that can convert once maybe a person pays a certain amount, whatever that is, how many months or a year or so, and then they could convert to Medicaid if needed.
Yes, absolutely. Yeah, when my father had a stroke, I was paying $20,000 a month for in-home care. And I can tell you, I was calculating, I'm like, how long is this going to last? Am I going to run out of money? And 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 he didn't. He was on hospice, but I used to be a hospice social worker, and I had people on hospice services for, a year or two sometimes. So it is. I understand the stress that families go through, especially these costs are for most people unsustainable, and that often is going to drive the decision making on, you want to provide care at home, but it's just financially after a certain point not possible for a lot of people.
I'm going to move back to the VA just to mention that Neva mentioned in the chat that the VA is also starting up what they call a medical foster home program. They're just starting up this program in San Diego. It will be paid for by the VA if the veteran is 70% service connected or more, but any veteran can go to one. And Neva, I'm assuming that's not just in San Diego. Is that right? It's potentially starting up in other areas. National, great, thank you.
And I did want to, Barb, I did want to
ahead.
go back to the Medicaid waiver and explain what that is. Medicaid is a federal state program. And initially, when Medicaid was created, it was designed to pay for care in nursing homes. We didn't have other options way back then. And so what they did was they created these what they're called waiver programs, which allow states to find other creative ways of providing care, and they have to get a waiver to use Medicaid funds that way. And so I will say for the state of Washington's always been sort of ahead of the game and thinking about long-term care, and for a long time has been shifting out of providing care in nursing homes, just again, for people's preferences and also because of the cost. And so that's why we're seeing in the Seattle area, I've noticed, some of the nursing homes I used to work at as a hospice social worker or just charge people to when I worked in the hospital, they're gone. And they're focusing now on the rehab component. So I hope that helps explain the Medicaid waiver. And every state is going to have their own programs. So it's hard to speak about the options because every state is slightly different.
And Alexandra is saying, aren't the waiting lists quite long for the waiver programs? Do you know?
So the waiver program, when we talk about waiver programs, it's the programs that are offered under Medicaid. So I wouldn't say waiting lists for waiver programs, but maybe for waiting lists to get into a place that will accept Medicaid might be long. And this is why, being on a waiting list, it's so hard. Because as I said, if the community is sold, the rules could be totally different. But you just do the best you can. And there are some places in sort of more out of King County, it's more likely that you would have options for assisted living or under the Medicaid waiver program, and also adult family homes.
And Alexandra had asked earlier about waiting lists for home and community-based services, so I'm assuming that's kind of similar then?
Yeah, I mean, I would only say that it really depends on the the area you're in and what you're looking for. Um, Sometimes if you're trying to set up home care, it might take, it's not going to always happen instantly. They need to get the staffing in place. And so this is why I think it's important when you're talking to patients or clients, you know, and they feel like they're in a crisis, that we kind of make sure that they understand that it might take a little while to get it all set up. So, you know, so that they don't have expectations that tomorrow they're going to have all the help they need. It just might take a little while, because every single service provider is really trying to find enough staff to do the work that they have available.
So I don't have any other questions. I don't see. Oh, here, Mary Pat said it depends upon the service. For home care, there is a shortage of caregivers nationally. Other waivered services include home delivered meals, personal emergency response units, wellness, education, living well with chronic condition programs. That's very helpful information, Mary. But it is quite a lot for families to have to navigate
It is, and this
and
is,
pay
yeah.
for.
And you can imagine, like, you're already stressed as a caregiver, you're worried about your loved one, and you're doing the best you can, and you just don't always have the time to try to figure it out. But there is help available. You can go to one of the amazing triple A's. You can find it if you're in a different state. And sometimes they're not called triple A's, but I'm going to use that term, triple A's. You can go through Elder Care Locator. I have a link on that slide. Alzheimer's Association, your local hospital social worker, you can call and ask for who could I talk to. You can, some of your clients might want to hire a private care manager. You can do that too. There's lots of options and people who can help navigate the systems. As I said, amazing home care nurses, and social workers and hospice nurses and social workers. If you know them, you can pick their brain. I know that, you know, they're happy to try to help you if you're a provider. So, you know, reach out to your colleagues and the people you know, and they can help you understand what's available in your area.
Um, I have almost a case study here that I'm going to read to you that came into the Q&A.
Okay.
And this person said they would appreciate your suggestions. This is an 83-year-old female whose husband died 3 years ago. Dementia increased rapidly since that time. Her personality is strongly independent and self-sufficient, so it's difficult to get her to accept the help she actually needs in the home. She can be contrary, combative, angers easily, and no longer has a relationship with her daughter. She's refused to let anyone in to make a diagnosis and has kicked home health providers out of the home when they come for a visit, stating she's fine. She isn't eating well, seems to be forgetting to eat and sometimes drink. She's dressing and sleeping, I think. She needs to use a walker but refuses. She's safe in her kitchen because the kitchen is non-functional, broken, stovetop, many complicating factors. My question is determining which setting is best for someone in this state, staying in own home where things are more familiar, or changing the setting completely and then being unfamiliar with daily habits and ADLs. What are your
You know,
thoughts?
this would be a great topic for Project Echo to help you navigate. And I'm happy to help you problem solve that. If you want to email me, my email is on the slide. That's a really complex case. What I will tell you really quickly, because I know we're going to run out of time. I had a client who was living alone, who had vascular dementia, who fell as a result of a UTI, went to the hospital, got delirium, discharged to a Geriatric who recommended that she go to Secure Memory Care. She called the moving company to come get her. She called her attorney constantly. She was very unhappy. Finally, they discharged her home with 24-hour care. She called her attorney every day saying she had a right to privacy and she wanted to kick them out. All of the aides were dressed as nurses. There was nothing wrong with her. Why were they there? And so I came in and you know what? We stopped the home care services because it was just agitating her. And I asked her if she would be willing for some of my friends to stop by. And she said yes. And so I started having companions stop by. I would introduce her. And I told the companions, when it seems like it's time to go, go ahead and leave. And over time, she started calling me to ask me if I had more friends who might spend the night with her. And so sort of letting go and letting some risk happen and not trying to force her too much really opened the door in time. It didn't happen overnight, in time to her accepting more and more help. And so what I would say is, keep building a trusting relationship and see what the person might be willing to accept. Use words that they can relate to, not you need help, but it seems like you might be lonely. Would it be okay if my friend stopped by? You have to start slowly, gradually working towards things that the person can accept. It can take time. Sometimes you have to call APS. There could be a whole variety of things going on there. But the most important thing is to build a relationship and take time to do that, and to know that you can't bubble wrap people. You have to allow some risk to happen. And know that sometimes it's just not going to be ideal. I can tell you, when we took away the 24-hour care, I did have slight panic attacks that evening, worrying about her falling down her treacherous stairs to the basement. But she did fine, and in time it all worked out, thankfully.
What an amazing case study both of those
Yes.
are.
I always say my clients are my greatest teachers, and she was a teacher, by the way, and she was one of my greatest teachers, and I absolutely adored her.
Well, this person said that they'll email you and check with Project Echo. Appreciate your help.
Right.
The woman did kick out one of her friends already, but maybe she can reintroduce and just keep working on this. So thanks
Yes.
so much for the suggestion.
Sure,
All
absolutely.
right, everyone, thank you. This was just really such an important topic for us to cover. Thank you so much, Dr. Gray, for sharing your expertise
Thank you for having me.
with us. And we will see everyone next week for our last session of this series. And in the meantime, have a wonderful weekend.
Bye, everyone.
Bye, thank you.
Thank you.